Okay, friends, good evening. So today we are joined by Dr. Vijay Kumar Sharma, who is a specialist doctor in the Walton Center, Liverpool. Basically, a PG from Raipur, year 2009, and he did his PDCC from Sri Chitra. He cleared his ADIC in 2018, and today he will share with us some pearls on neuroanesthesia, recent advances in neuroanesthesia. So over to Vijay, and all yours, please.
Thank you, Anil sir. So, as for the continuation of presentation, today we are going to discuss about the recent advances in the last couple of years, what happened in the neuroanesthesia. So, before moving, just I wanted to tell that few of the photos which I have used in my presentation, they are not mine. I have taken from the internet, and there is no conflict of interest in this presentation. To start with, let's start with the daycare cranial surgery. So we have already seen a lot of daycare surgeries are done nowadays, and there are a lot of benefit of daycare surgeries. It reduces the cost of the patient. It reduces the waiting time of the surgical patients as well as infection and other risk factors. So already spine surgeries are, we have already started doing a daycare spine surgeries as well as in other centers in India and abroad. Spine surgeries are already done in daycare cases. But in cranial surgery, it is not very common. So this was a review article which was published, and in that they have seen some case series in which same day brain tumor resection was done, and these patients were discharged at home on the same day. So they have found the 91% of the patients they got discharged, and in that they found 5 series in which the tumor biopsy was done, and 92% of the patients were discharged on the same day. As well, they found that some aneurysmal clipping, in which there were 25 patients case report, in around 68% was discharged on the same day. So from these studies, they found out the cases which are supratentorial mass lesions or supratentorial lesions or supratentorial biopsies. They can be done under daycare surgeries. Those patients who have unruptured aneurysms or unruptured aneurysms of anterior circulations, they can be done as a daycare surgeries. Surgical duration is very important. It should be less than 4 hours to discharge the patient in the evening. Patient should have low to moderate risk of medical complication. It means ASA physical status should be around ASA 1 or ASA 2. The care provider should be available round the clock to the patient, and he should be aware about the danger signs and danger symptoms, in which he need to aware when he need to connect with the doctor or healthcare responders. At the same time, the patient should be in near vicinity of the hospital, and patient can at any time in emergency can able to contact and come down to a hospital or nearby. Other area which has been seen in these few year or this decade, that it has been improved uh, and seen a lot of surgeries done, is minimal invasive neurosurgery. Invasive neurosurgery benefit are same, that the hospital stay is less morbidity, patient can be discharged earlier, low cost, low waiting time. So they're uh, because all these advantages, there is a rapid growth of functional neurosurgeries, and it has been doing in most of the cases of Parkinson's disease, dystonia, refractory epilepsy, or pain. So so these are the patients. They have some consideration. We can divide these consideration into two part: patient related consideration or procedure related consideration. We know that these patients, those who come for a surgery, they are either a Parkinson's disease, having a dystonia, or having a tremors. So these patients, Parkinson's patients, they have autonomic instability. They have airway concerns because of dysphagia or poor cough. Their mental status is not good. They, most of the time, they are dementic, and cooperation is it's difficult to get a cooperation from the patient. They are on multiple medications, so they have a lot of adverse drug reaction and some of compatibility issue with our medical anesthetic agents. They have in hemodynamic instability. The dystonic patients, they frequently go in a laryngospasm. Patient positioning is difficult because of the contractures they have. The essential tremor patient, they are on multiple agents, frequently on a beta blocker, so they might have a bradycardia and they can mask symptoms. Epileptic patients, they are on multiple anti-epileptics and they altered our drug metabolism, especially related to the muscle relaxants. So they require a high doses of muscle relaxants. Some of the extreme age, which is related, so pediatric patient, they have their own anesthetic consideration regarding airway, regarding temperature management, regarding blood and fluid management. So procedure related considerations are, most of these patient these procedures are done in remote location and remote location anesthesia. So intraoperative MRI, they have their own consideration because the patients are in frame. Airway should be maintained properly. Frame should be used in when the patient is on a frame. And ultrasound suits, they are also in a remote locations. So when the patient is on a frame, the airway is not in our hand, and it's we have only limited access to it. So all these considerations need to be focused when a patient is going for a functional neurosurgery. So there was a one review article which came in on a functional neurosurgery and their implications. So it was saying there are different areas of functional neurosurgeries are being these days have been advanced. Some of them are laser thermal ablation therapies, in which the probe is placed into the region of the abnormal tissues, and those tissues are ablated. Some of the surgeries are done intracranial on spinal tumors to ablate those tumors, or epileptic foci to particularly ablate the perfect foci which is creating for epilepsy. Most of our colleagues, those who are doing regular neurosurgery and functional neurosurgeries, they are well aware about the stereotactic head frames and their concerns, because these stereotactic head frames basically used for to know about the 3D structure, depth, and exact location of the lesion, exact location of the probe placement, or exact location of to do a biopsy. So and we know once the patient is on a head frame, it's a difficult to access the airway, because the surgical site and on a head airway both makes the airway, a simple airway, into a difficult, challenging condition. So there was a study which came, it was a mannequin study in which they tried airway management, and it was a basically simulation type of simulation, airway simulation, in which how to respond airway when the patient is on stereotactic head frame. So they enrolled 30 anesthetists, in which 7 were resident, 12 were fellows, and 11 were staff. And the airway was secured by putting an LMA or intubation. Intubation was direct and video laryngoscope. So they found out that resident take around 29 seconds longer than fellows to secure an airway. So by this we can know that this is really a good simulation of a crisis management, and a good learning for residents, those in the national institutes, to learn about the airway management when the patient is already on a stereotactic head frame. Awake craniotomy has revolutionized neuroanesthesia, as well as some of the tumors, or which was very difficult to resect in old age when we were not aware about the awake craniotomy. And these days we frequently see in our newspapers some kind of these news keep coming. The patient was playing guitar, the patient was talking, or the patient was um, uh, the patient was playing or writing down while surgeon was doing a resection on his brain. So basically, if we see there are two different techniques of doing awake craniotomy. One is asleep, awake, asleep, which is now not so common technique, in that we induce a patient and then we secure a airway with igel or LMA, and when the surgeon reaches on when surgeon does a craniotomy, bone flap is removed, dura was resected, and then cortical mapping was done. Patient was waked up, all the areas were assessed, and after a resection patient is again back to sleep. Patient and again airway is secured with LMA or igel. The other one is a fully awake technique, in which the most common is giving a scalp block. Scalp block is giving 6 injections in one side, so total 12 injections. These are supratrochlear nerve block, supraorbital nerve block, zygomaticotemporal block, auriculotemporal block, lesser occipital and greater occipital nerve block. After giving a scalp block, sedation is usually the sedation is started in term of dexmedetomidine or propofol and remifentanil or fentanyl infusion. So the goal of awake craniotomy is we have to make the patient comfortable during the cortical mapping. The patient patient should be rapidly aroused, awake, clear-minded, so that he can participate in neurological assessment. So there was a one study, this was done to know the propofol pharmacodynamics and bispectral index during awake craniotomy. In that, they divided into two groups. One group has received propofol and remifentanil as per the Marsh model along with the BIS. Other one has received propofol and remifentanil as per Schindler's model. And they measured the plasma concentration and BIS. They have found out that when they have stopped the infusion, the consciousness was returned at around 11 minutes when the BIS was corresponding to 77. The neurological testing was facilitated after around 23 minutes when the BIS was around 92. And the main thing which was found that Marsh model injects a large doses of propofol than the Schindler's model, and Marsh model, that's why the Marsh model takes a little bit extra time for the patient to wake up than the Schindler's model. Other surgeries which is frequently done on in the volumes of surgeries which is done in the neurocenters are the spine surgeries. Almost all spine surgeries from the cervical to thoracic, lumbar, most of the surgeries are done to fix a spine because of the trauma. Some surgeries are done to remove tumors or some lesions. Some surgeries are done to fix a spine for the degenerative changes. Cervical spine is in among them are the most challenging one, because if it is an unstable cervical spine, we are more concerned about the secondary injury, and we don't want to patient to have a secondary injury. So we want the cervical spine to be in as neutral as before the patient going for a surgery. So there was one report, clinical study came in which they compared two instruments. One was Shikani optical stylet, another was fiber optic awake. They did awake intubation, and all the patients were unstable cervical spine, and they compared with the Shikani optical stylet with the standard fiber optic laryngoscope. So they found that they randomized 60 patients into the equal, and they found that successful intubations were faster in Shikani optical stylet than the fiber optic laryngoscope. Coughing, gagging, sore throat, intubation in first attempts were almost similar. They found out that Shikani optical stylet is also one of the good instrument for awake intubation in cervical spine, and they found out it's not it's much safer, as safer as the fiber optic. Few studies came on the spine surgeries, post-operative analgesia. One of the study was very interesting, which has used low dose of naloxone in a patient with in a patient control analgesia with a morphine to found pain relief, in which they gave a low dose of naloxone to enhance the analgesic effects of the morphine. Dose of naloxone uh, enhances the enkephalin release, and we know the enkephalin is one of the analgesics, natural analgesics. So they gave a 0.25 microgram per kg per hour naloxone for 24 hours, and they assessed pain, pruritus, and nausea at around 1, 6, and 12 and 24 hours. So they found out the group in which naloxone was given, they had lower pain scores, they have lower nausea and lower pruritus. The same time, there was a one more study came in 2019 in which they randomized patients, spine patients, in two parts. Most of these cases are from the lumbar discectomy, lumbar corpectomy, lumbar fixation, and these patients they divide into two parts, in which they gave in one group they gave 0.25% of bupivacaine with 20 ml plain, and another one they gave a 0.25% bupivacaine with 150 microgram of clonidine, and they gave a field block before giving a surgical incision. All the cases of lumbar laminectomies, lumbar fusions, microdiscectomies, and lumbar cervical laminectomies were included in that, and they found there's a significant reduction in the pain and total morphine consumption in the patients who are receiving bupivacaine along with the clonidine. There was an argument. There was an argument in this study that this might can be because of the local absorption of the clonidine. When we are giving a clonidine, it might get absorbed into the circulatory system, and it might cause it might give the same effect which is uh, given by IV also. So acute ischemic strokes. Now, in recent years, it has been seen the mechanical revascularization is a much more preferred way than the conventional intravascular thrombolytic therapies. And we know as the time goes, the prognosis become more poorer than the earlier. So it is always advisable to have early thrombectomies or early thrombolytics therapy. So there was a 2018 study in which they divided it into two group, the patients who presented in 6 to 24 hours after the stroke. So they divided. It was a randomized trial, and they divided into two groups: those who are receiving mechanical thrombectomy and those patients who are receiving the best medical management. So those patients who received under the window period or less than 6 hours, they received mechanical thrombectomy, and those patients who received after the window period, they received medical management, and they found the mechanical thrombectomy was superior than the medical management, and but there was symptomatic ICH and mortality rate, 90 days mortality rate was similar in both the groups. But if we see the modified ranking scale outcome, that was better in mechanical thrombectomy patients. So probably after I think mannitol and hypertonic saline debate, the most common debate is to which type of anesthesia is better for mechanical thrombectomy patients. So general anesthesia or or local or sedation. So it has been debated, and there were some studies, observational studies in few years back. They suggested that those patients, those who are intubated or given a general anesthetic, they have a poorer outcome. But those studies might be biased because that time more and more emphasis was given to give sedation or conscious sedation to a patients for mechanical thrombectomy to assess the neurology at the time of the thrombectomy procedure itself. And those patients who were who were who were who was given a GA, they were already having a poor neurology, or they have a worse kind of stroke at that time. So it seems those observational studies were biased. But these two studies, they had a proper randomization, and then they found out there's no not there there was no difference between general anesthesia or sedation, and general anesthesia was not associated with the worst outcome in acute ischemic stroke. Sedation and general anesthesia, they both had the similar mortality, 30 days of mortality, and there is no other advantage of the conscious sedation. There's one more study which came in JAMA Neurology. And this was a single center study in Denmark, and they found out it was a Goliath trial, and they found out that though there is no difference between outcome between the general anesthetic and local anesthesia, but the revascularization was much better in general anesthetic patients. So it was a single center prospective randomized trial. Patient received propofol remifentanil infusion as a GA case, and as a conscious sedation, they received low dose of propofol infusion and bolus doses of fentanyl. And there was no difference in primary outcome, but reperfusion was greater in general anesthetic cases. Might be because the patient were immobilized, and the neurointervention radiologist, they got their own time to and they were not much focused about the neurology, much more focused about doing the procedure, and they got more reperfusion. Subarachnoid hemorrhage is even after a lot of development in the treatment and in all other all intensive care, still aneurysmal subarachnoid hemorrhage has highest morbidity and mortality, if we see. So there was a one study came, and they did a clinical survey, and they found out there's a difference in the trend in last few years in management of the subarachnoid hemorrhage, and those were like increasing the use of the nimodipine. So subarachnoid hemorrhage, as the patient arrives, nimodipine is started, irrespective of diagnosing as aneurysmal or non-aneurysmal, and it is continued then later on. And the earlier treatment of the ruptured aneurysm, previously the old thinking was to, if the aneurysm is ruptured, to wait for 14 days till the vasospasm period is wean off, and the patient can be taken for neuroradiological interventions or clipping. And more patients, they are going for a coiling, and there is a drastically reduce in number of the clipping. In my center, probably in 1.5-2 hours, I have done only one clipping. So around more than 95-98% patients, they are going for a coiling, and all the coilings, majority of the coilings are successful in that, and they have less morbidity and less mortality. The second thing which I have changed in these last 2 or 3 years, that I have stopped using a prophylactic anticonvulsant. So this is a trend which has been seen. There is a drastical decrease in using a prophylactic anticonvulsant even in the open neurosurgery patients. Induced hypertension, which is used more frequently nowadays than triple H therapy. So, as we know, the dexmedetomidine is rampant use in the neuroanesthesia and neurocritical care. So this paper came in Journal of Critical Care, in which they used dexmedetomidine as a sedative agents, and they have first the study which came in the rat models, in which they have shown that dexmedetomidine reduces the cerebral edema and it improves the neurological outcome. And subsequently, they did a study in aneurysmal subarachnoid patients, and they enrolled 161 patients divided into three groups, in which the patient doesn't receive dexmedetomidine sedation. The other one, the second group of the patients, those who receive low dose of dexmedetomidine, and the third one which receives high dose of dexmedetomidine. So low dose of dexmedetomidine is 0.01 to zero point 0.2 microgram per kg per hour. High dose is more than 0.2 per kg per hour, and they have seen the patient who has received low dose of dexmedetomidine, they have significantly lower lactate level, they have a better outcome than the high doses of dexmedetomidine. Probably, maybe because of when we are giving a low dose of dexmedetomidine, it 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 reduces the hypercatecholaminic state, which is seen just after subarachnoid hemorrhage. And but when we are giving a high dose of dexmedetomidine, it causes a hypotension and then reduces perfusion. So there is one more study which was used as a biomarker. As we know, the biomarker are frequently used in clinical practices, and most perfect example of a biomarker which we use is CRP or procalcitonin in critical care to know about the infection. The same type, they have used red cell distribution in subarachnoid patients to find out the prognosis of the and they have found out patients, those who have a high red cell high cell distribution with, they have a poor outcome. So they enrolled 270 patients of the subarachnoid, and all the patients were reviewed. High red cell distribution with, when the patient was in ICU, it was associated with the poor outcome, and increased red cell distribution with independently was predictor of in-house mortality. Traumatic brain injury, as we know, the more and more when we are the research is coming on a traumatic brain injury, the more and more we are following protocolized and guideline method of managing traumatic brain injury. And we know the main area of a traumatic brain injury is to lessen the secondary brain injury, or to reduce the secondary brain injury. So there was a one survey was done between the American College of Surgeons, the traumatic brain improvement program, in which they found out that the management of traumatic brain injury in dedicated neuro ICU or general ICU, and they have compared this basically it was a program in trauma quality improvement program registry, and they have enrolled 134 centers which was responded in this survey. And they found of rate of tracheostomy, pneumonia, length of stay, and mortality were same between both dedicated as well as the general ITU. And interestingly, they found out low mortality is adhered to a standard protocol. So it doesn't mean the patient, if traumatic brain injury patient needs a dedicated neuro ITU, if the ITU is following proper protocol, it can be managed in general ITU also. And when we are adhering to a standard protocol, outcomes are better. So the center is not important here. The important is adhering to protocol. Probably this is the most common debate everywhere regarding osmotherapy, which is good, hypertonic saline or mannitol, and it's still going on in last 30 years. Might be this study put an end on this, but they have compared 3% hypertonic saline with the 20% mannitol in intracranial pressures. So they have used hypertonic saline and mannitol in 39 patients, and all were elective supratentorial craniotomy. So they have given a osmotic therapy, and the surgeon who has graded the brain relaxation. So they have divided brain relaxation into four part one. Grade 1 is fully relaxed, and grade 4 was tensed brain. And they found out mannitol significantly increases the serum lactate level, though hypertonic saline have a significant increase in pulse pressure variation. And mannitol causes significant decrease in intravascular volume and tissue hypoperfusion. So they found out hypertonic saline has better brain relaxant qualities than the mannitol, and it's a much better agent if we want to use as a osmotic therapy. Now, from the treatment, we are moving towards a monitoring, cerebral monitoring. So, cerebral monitoring, our aim is to monitor the cerebral blood flow. There are different methods are there uh, to calculate a cerebral blood flow, but still, CT angio is the best method to calculate the cerebral blood flow. But it needs the patient to shift in CT scan suit, and it's sometimes it's a very difficult if the patient is unstable. But there are different other ways to monitor cerebral blood flow. The most common most popular is transcranial Doppler. The other one, which has recently has been come is ultrasound tagged near infrared spectroscopy. So they have the recent study in which they compared both the thing, transcranial Doppler with the ultrasound tagged near infrared spectroscopy, and they found that um, they have volunteered healthy individuals for this study, and they did a study in hypocarbia as well as a hypercarbia state, and they found out that still ultrasound tagged near infrared spectroscopy has a limitation, and it's required some additional refinement. Till now, when these all things are not done, probably we will keep hunting for a better monitor for cerebral blood flow. So complication in neurosurgery, basically we can divide it complication neurosurgery in two parts, the cranial as well as the spine. And the American College of Surgeon, this quality database, which has tracked the complication from 2005 to 2015, which is a handsome data of 10 years. They have enrolled 603 medical centers in US, and 22% complications they found out in the cranial cases, and 11% complications in the spine cases. So ASIC physical status of 5, 4, or 3, they had the strongest predictor of mortality. Obviously, these patients are not going to perform well. Other one was a study which was came in 2019. In this, they have found out it was a closed claim report from 2004 to 2014, and they found out that spine surgeries which was done, most of them were the non-spine procedures which have more complications. It means the cranial one. The spine procedure has the minimal complications, and they had minor complications. Major disabling complications were in spine procedure, which was explained because these patients, they come most of the time with the neurological deficit, and they have found out the most common complications in the spine procedures are hemorrhage and infections. Though in cranial, they are infections and neurological deficit. So I want to end my presentation with a beautiful thought that if we would have new knowledge, we must get a whole world of new questions. So after going through all these studies, uh, probably the more questions will arise in our mind, and still we are hunting for a very good monitor which can solve our queries about cerebral blood flow, and better and better patient management, especially in the acute conditions, which are going to change the patient outcome and morbidity. Thank you.
Okay, thanks, Vijay. That was really nice of you after a hectic night duty, and I can understand how hectic it is at your center. So, one basically query from Suren. He's saying that in a neuroradiological suit, keeping head without movement becomes an issue under fluoroscopy, right? So, isn't GA better in those circumstances, or like what is your opinion?
Especially in which cases he is more interested, because what cases which we are doing, all thrombectomies nowadays what we are doing under general anesthetic, and it is good for us as well as the uh, in, intervention neuroradiologist, because we need not to think about the patient struggle, and we not need not to move all around the ducts of the fluoroscopy. And it's really very difficult when the neuroradiologist is on the critical step and the patient deteriorates and we need to intubate the patient. So nowadays what we are doing, we are giving blanketly general anesthetic to all the patients. And because of availability of good anesthetic agents, propofol, remifentanil, or desflurane, we can try to extubate as soon as possible after the procedure.
Okay, so I remember in our times it was something like this, that an awake patient serves as his own monitor. So maybe that has gone into background, like GA, like you said, that it should be given or it is given at your center. Is it like that?
Um, because recent studies, which I mentioned, that there is no difference between outcome, but
Right.
we have seen the reperfusion is much better than the sedation one. Probably, what I can interfere with these studies, that if the patient is under sedation and the patient is continuously moving, and patient is not, because already these patients after having a stroke they have a dysphagia, they are not able to move their hand, they have a lot of apprehension, anxiety, and they won't understand all these things, so they keep moving it and in and around, and it's very difficult at that time for intervention radiologist to do his procedure. When the patient is already intubated and sleep, they have their comfort time and patient is not moving. So I feel it's easier for them to do the procedure.
Okay, one question is what is the role of supraglottic devices in neurosurgery?
Supraglottic airway devices, as I told, few of consultant over here in my center, they are doing still awake craniotomy as asleep, awake, asleep, and we are putting supraglottic airway devices in these patients. So what we are doing, or what I have learned over here, that once the patient is induced, we will put a eye gel, and the Mayfield was clamped, and we tell the surgeon to put the patient in a position. That time we will take out the eye gel in that position, and again we will reinsert, and we'll check whether that position is comfortable enough to for a reinsertion of supraglottic airway devices or not. And if it is easier, then the whole surgery can be conducted as with the eye gel only.
Okay, one question is how much CO can be given. I think it's about how much MAC or to what level you go. That's what the question might be.
So generally, we are not going above 1 Mac, and most after working probably here, I have realized uh, Tiva is much better than the inhalational agents in neurosurgery patient. And recently, I had encountered a patient who had a aneurysmal subarachnoid hemorrhage, and this patient had a PCOM aneurysm bleed, and the patient was taken inside a radiological suite, and the patient was uh, uh, aneurysm was coiled, but there was a huge hematoma inside, and they wanted to decompress it. And that time I saw the best benefit, the brain got relaxed by Tiva. And Tiva is a wonder than giving an inhalational agent. But though I can understand that one few of our friends, they have a limitation. They don't have a luxury to use Tiva, proper Tiva, which I am mentioning, with the pumps and proper analog. But if I'm using inhalational agent, I won't go more than a 1 Mac of Sevo or 1 Mac of Desflurane.
So, do you routinely avoid prophylactic use of anti-epileptic drugs?
Recently, this is again a new thing which I have learned from last around two years. I am not using any prophylactic anti-epileptic drugs, because conventional fundamentals which I was doing, also pretentorial surgeries, I was using prophylactic anti-epileptics.
Right.
But after coming here, I have seen, even when we are not giving prophylactic anti-epileptics, patients are doing well. They don't have any seizures. They're very probably rare cases I have seen any seizure. Even I heard, I haven't seen myself. So I think what I was doing earlier, probably that was not needed.
Right. So, and so the same is about the prophylactic use of steroids. That is one question. So you
Uh,
avoid.
no, I feel on all tumor patients better to use steroids, because they have a vasogenic edema, especially the gliomas and all those high grade gliomas. They have severe kind of brain edema. So and steroids work as a wonder in that. And few of the time I have seen, even I haven't gone through any literature about that, but they say in even subdural hematoma, SDH, also steroid should be given. But I'm not convinced till now.
Okay. So do you give anti-epileptics in aneurysmal SAH only after the patient throws seizures?
As
This is
aneurysmal
what.
SAH, prophylactically we are not giving until unless patient has a high risk of seizure complication. If the patient has a history of having a seizure in the past, or if the patient is on other anti-epileptic agents preoperatively, then we give.
Okay. There is a question from Vidya Madam. In which subset of patients are you avoiding prophylactic anti-epileptic drugs?
um, Almost all patients we are avoiding anti-epileptic agents. We are very selective in giving prophylactic anti-epileptic agents nowadays. So only those patients we are giving anti-epileptic, those who have a high risk of seizures, or they are already on anti-epileptic agents.
So, do you recommend TIVA if we don't have target control infusion pumps, or remifentanil is not there?
Remifentanil is not the mandatory for the TIVA, but it is a very good agent if we are giving TIVA. But I won't recommend anybody to give a TIVA without target control infusion, because after doing a TIVA with target infusion, I came to know that we were giving around 20 to 30 ml, which is a sedative dose. Basically, it's not the TIVA dose. TIVA dose goes somewhere around 50 to 70 ml per hour of propofol, and remifentanil goes somewhere between 11 to 15 ml per hour. If we take a 50 microgram per ml concentration of remifentanil. So most of the time we are underdosing if we are not using target control infusions. And I have seen, this is my personal experience, people or some of our colleagues, they used to say, if the patient is not given a relaxant, and if patient is not moving, it means patient is properly anesthetized, which is wrong. This I have even put a notice also, that even if patient is not moving, patient will be aware. and when we will tell the patient on his name, patient will obey our commands. That we have seen in sleep awake sleep technique.
Okay. So one question from Dr. Raghavendran. Sir is asking, do you do any endoscopic procedures, skull-based procedures apart from transsphenoidal surgeries?
Yes, sir. Apart from transsphenoidal surgeries, we are all endoscopic third ventriculostomy and other regular surgeries we are doing.
Right. And Dr. Vijit wants to know, like, induced hypertension, how low mean blood pressure is allowed?
We are not reducing blood pressure in any intracranial surgeries until unless it is a AVM resection, or nowadays even the AVM also, almost all the AVMs we are embolizing through intervention neuroradiology. So
Right.
there we are doing one nowadays. There is a study which we are doing it, in which from the both the sides is going, and we are reducing systolic somewhere around 80s to 70s, so that the maximum area of embolization can embolization can cover the maximum area of AVM.
Right. So one question from Dr. Dharia is, how much hypertonic saline you are using for relaxation of brain?
So we are using somewhere around 50 to 100 ml of 5% hypertonic saline, which is quite enough dose to for a normal adult male for a brain relaxation.
Okay. So Dr. Vidya is asking, what if the patients have already been started on anti-epileptic drugs? Then what you do?
I would suggest I would continue it, because there's no harm in continuing the anti-epileptics. And if it has already been started, it means there had been some risk factors, or patient has already been had been fits. So to stop those fits, it has been started. So we'll continue it.
Right. So I think that's it. And thanks. After your night call, I can understand with all this amazing, I mean to say, all the studies that you showed us, and for the nice update. Okay. Stay safe. Take care, dear, and
Thank
enjoy
you.
with your daughters. Congratulations. Okay. Thanks. Yeah.
Thank you.
Thanks. Thanks
Thank
for the nice presentation. Thank you very much.